Welcome to the RSNA Radiographics podcast. My name is Jessica Leschied, and I'm a pediatric and musculoskeletal radiologist at Vanderbilt University Medical Center in Nashville, Tennessee. So I'm doubly excited to discuss today's podcast reviewing a hot-off-the-press article entitled Summary of Intra-articular Osteoid Osteomas, Imaging Appearance Manifestations, and Mimics. Our authors include Alejandra Bedoya, Jade Iwasaka Nadir, Andy Tsai, and Sarah Bixby from Boston Children's Hospital. This article reviews the intra-articular osteoid osteoma and how it can sometimes be dramatically different from its clinical and imaging presentation in comparison with the extra-articular variety. Familiarity with this type of OO by radiologists can help avoid misdiagnosis, which can lead to unnecessary treatment, including arthroscopy or surgery. Osteoid osteomas are benign bone tumors that represent approximately 10% of all benign bone tumors. From here on in, I'm going to refer to them as OOs. While they may have a classical, clinical, and sometimes classic imaging presentation, there are many atypical OOs that elude a diagnosis because of an atypical location, unusual size, or unusual patient characteristics, such as older age at presentation. The intra-articular OO is considered an atypical OO as it represents less than half of the prevalence of OOs and often has unusual clinical and imaging features that may mimic alternative pathology. The purpose of this comprehensive and multimodality review paper is to highlight for the reader the imaging features of an intra-articular OO that should prompt the radiologist to consider or suggest this as a diagnosis. This review will cover briefly the pathophysiology of the OO, the clinical course of the disease process, the most common locations that intra-articular OOs are located, and then an emphasis on imaging appearances of this type of OO. Let's talk about the pathophysiology. Histologically, the origin of the typical OO is a vascularized osteoid-producing nidus that has the ability to release large amounts of inflammatory mediators such as prostaglandins, which explains the clinical symptoms of pain that responds to anti-inflammatories. Generally, the nidus is small, measuring less than 1 centimeter, demonstrates various degrees of mineralization, and is surrounded by a fibrovascular rind. The surrounding bone often reacts to the lesion by producing a densely sclerotic rim. The syndrome associated with OO tends to occur in young people ages 10 to 25 years old with a male predominance. The intra-articular variety of OO is less well understood as the symptoms may be atypical. For example, the diagnosis is often delayed as symptoms are more nonspecific. Pain may be atypical, it may not respond to anti-inflammatories, and often the symptoms are more reflective of the presence of reactive synovitis, resulting in joint tenderness, joint effusion, and restrictive range of motion. Therefore, these children and adolescents tend to be misdiagnosed with inflammatory conditions like juvenile idiopathic arthritis, septic arthritis, a stress reaction, femoral acetabular impingement, or labral injury in the setting of a hip OO. Unfortunately, this delay in diagnosis can result in unnecessary interventions like arthroscopy, osteoplasty, or pinning, not to mention the consequences of incorrect or delayed treatment, resulting in joint pain, contractures, and loss of participation in athletic activity. Intra-articular OOs have most commonly been described in the hip, and within the hip joint, most occur at the anterior femoral head-neck junction. Less common locations include in the elbow, at the olecranon fossa or medial epicondyle, or in the carpal or tarsal bones. Within these locations, they may be intramedullary, intracortical, juxtaphyseal, or subchondral. Once a diagnosis is made, treatment options include conservative management with anti-inflammatories, surgical resection, or image-guided radiofrequency or cryoablation. Treatment options are not discussed in this article. Let's move on to the imaging features. Intra-articular OOs tend to be much more subtle on X-rays and may just show up as a small lucent or sclerotic focus, or be altogether occult. A dense nidus is only appreciated in 30% of the time. It's rare to see cortical thickening or periosteal reaction, given the lack of periosteum in the epiphysis and the histology of intracapsular bone. Because of the proximity to the growth plate and the stimulation of blood flow to the region of the OO, it may present on radiographs as a mild skeletal deformity, such as coxa breva or coxa magna, coxa valgus, or osseous overgrowth. CT is still considered the favored modality for detection of all OOs, and thin section CT with bone algorithms is preferred for diagnostic and potentially for planning therapeutic intervention. The CT appearance of intra-articular OO is very similar to the extra-articular OO. There's usually a well-defined round lesion with low attenuation, variable density of the central nidus, and a well-defined sclerotic margin. Unusual features that have been described on CT include small size, less than 5 millimeters, a lack of a calcified nidus, and no surrounding sclerosis. The utility of MRI is still controversial, though in my experience it often takes the combined appearance of the lesion on radiographs, CT, and MRI to make the diagnosis, so MRI is often acquired. In one investigation quoted in this review article, CT was found to be accurate 80% of the time in diagnosing an OO, compared with 19% of the time for MRI. Furthermore, MRI may not be performed with gadolinium if the diagnosis is not suspected. Regardless, the features of OO on MRI are nonspecific and include geographic bone marrow edema-like signal and enhancement if gadolinium is given. The nidus is often not easily appreciated on MRI. Intra-articular OOs often incite an inflammatory response in the joint, and so joint effusion, synovitis, and surrounding soft tissue inflammation are often present and may be clues to the diagnosis. However, it is these same findings that, in the absence of CT correlation, may send the patient down the incorrect workup, instead looking at things like juvenile idiopathic arthritis, infection, or chronic non-bacterial osteomyelitis. It's important on MRI to exclude labral pathology, signs of femoral acetabular impingement, or cartilage abnormalities, which all may be in the differential diagnosis. If the diagnosis is still in question, there may be a role for either bone scintigraphy or PET-CT. A bone scan is nearly 100% sensitive, but only 38% specific, and while PET-CT improves localization of the lesion in question, it is associated with high radiation exposure and cost. The combination of bone scan and SPECT-CT has a sensitivity, specificity, and accuracy of 100%. The characteristic finding of the OO on bone scan is the so-called double density sign, which is a central area of striking uptake, or the nidus, which is surrounded by a region of low uptake representing surrounding reactive bone. The differential diagnosis for OO includes a stress reaction, infection, either osteomyelitis or a septic joint, inflammatory arthritis, chronic non-bacterial osteomyelitis, or other bone lesions such as a chondroblastoma. If in a subchondral location, an osteochondral abnormality may also mimic an OO. This review paper demonstrates a really nice table describing the differences and similarities between these diagnoses and the intra-articular OO. In summary, the presence of a joint effusion, exuberant synovitis, bone marrow edema on MRI, and presence or absence of a nidus, often in the presence of atypical clinical symptoms, should prompt the radiologist to consider a diagnosis of intra-articular osteoid osteoma. Ultimately, the diagnosis may require a comprehensive review of the lesion features on radiographs, CT, MRI, and possibly nuclear medicine studies, and consulting with other radiology colleagues may increase reader confidence. It may save the patient from unnecessary surgery or the debilitation that may ensue from a non- or delayed diagnosis. Thank you for listening to my summary of this very thorough and delightful review article entitled Appearance Manifestations and Mimics of the Osteoid Osteoma. I'd like to acknowledge our authors again, Alejandra Bedoya, Jade Iwasaka Nadir, Andy Tsai, and Sarah Bixby from Boston Children's Hospital. Please remember to rate, review, and subscribe to our podcast, and I direct your attention to our journal website to read the article discussed. And you may also check out other great published articles and podcasts on this website. Thank you for listening, and have a wonderful day.